I'd like to introduce, we're going to switch gears a little bit here this afternoon and talk first about ADAP. And I think a lot of people in this room know why this is such an important program, the AIDS Drug Assistance Program. But yesterday, NASDAD released a report saying that almost 10,000 people are on waiting lists for ADAP drugs nationwide. And as somebody else earlier today, I think Dr. Fenton pointed out, that the majority of people, the majority of states where that's occurring are in the South and the Southeast, where much of the new infections are also occurring. So the fact that these states have these gaps in ADAP coverage is really a disaster, and hopefully will be improving soon. This is one of those situations where the personal and the political come together very closely. I think for a lot of people, you've had either yourselves or friends who've benefited from the ADAP program. I personally don't think I would be standing here today if it weren't for California's extraordinarily generous AIDS drug assistance program that I took full advantage of from 1991 until 1997. And having had those drugs enabled me to come back to work and have a second career and a second chance at life in many ways. So when we talk about ADAP, I think a lot of us have a very strong heart connection to ADAP, and it's really a critical program for many people. And I know there are other people in this room for whom that's also true. Today, to talk about this from two different perspectives, one from sort of a research and policy perspective, and another from a state AIDS director's perspective, are Dr. Erika Martin and Dr. DeAnn Gruber. I was looking at Steve Shoptaw's notes, sorry. So first I'll introduce Dr. Martin. She's an assistant professor in public administration and policy at the Rockefeller College of Public Affairs and Policy and an institute fellow at the Nelson A. Rockefeller Institute of Government, which, not unsurprisingly, is at the University of Albany at the State University of New York. She teaches an undergraduate and graduate courses on policy analysis, methods, and health policy. Dr. Martin has examined the fairness and flexibility of the federal allocation formula for the Ryan White HIV/AIDS program, interstate variations in state AIDS drug assistance program drug formularies, and the budget impact of expanded HIV screening in public payers. Dr. Martin.
Great. So thank you so much for the opportunity to come here. Thanks for braving the post-lunch slump. I've been a bit sleepy. And thanks also to the conference organizers for putting together a really interesting day. So Dr. Fenton, in the first talk, discussed a lot about inequities. And so here in this talk, I'm going to focus on inequities in state policies, particularly related to ADAPs. And this may in turn lead to differences in access to mental health and substance abuse medications. So what I'm going to talk about more specifically, first, a background on how HIV, mental health, and substance abuse treatment are financed. Findings on the inclusion of psychotropic medications on state AIDS drug assistance program formularies. Some very early work on substance abuse medications on these formularies. And I wanted to end with some future opportunities and challenges that we have going forward. So as we've been talking about all day, treating comorbid mental health and substance abuse disorders is a really important part of clinical care for people living with HIV. Over half of people living with HIV in the US have had a psychiatric disorder. Severe mental illness may increase behavioral risk factors for HIV infection, particularly bipolar disorder and schizophrenia. And people with untreated substance abuse disorders are more likely to engage in high-risk behaviors. So in that sense, treating substance abuse is therefore an important part of HIV prevention. Depression may worsen HIV disease, thereby increasing AIDS-related mortality. Symptoms of HIV may be similar to symptoms of depression. The social effects of having HIV may in turn lead to depression. And depression and substance abuse have both been found to reduce adherence to antiretrovirals and also retention and care. People living with HIV navigate through a really complex funding system for HIV care. Only about 15% of people with HIV have private insurance. So one of the main programs which provide access to medications is Medicaid. Most people living with HIV qualify for Medicaid through pretty strict categorical low-income and disability requirements. And Medicaid is an entitlement program. This is important because that means that the budget automatically expands and contracts in response to changes in underlying need. The second major program that finances HIV care is Medicare. Since Medicare Part D was implemented a few years ago, Medicare is now the largest source of federal funding for HIV care. Similar to Medicaid, people on Medicare have to meet some pretty strict categorical requirements, and they generally qualify through permanent disability or age 65. And like Medicaid, Medicare is an entitlement program. So as you might imagine, Medicare and Medicaid eligibility rules exclude a lot of people living with HIV. So the Ryan-White program was created in 1990 as a payer of last resort for people with HIV who are uninsured or also underinsured. Its main target is people who haven't yet progressed to AIDS. Unlike Medicare and Medicaid, it's designed exclusively for HIV care. And Ryan-White runs and funds AIDS drug assistance programs. ADAPs finance HIV medications for about 30% of people living with HIV. And unlike Medicaid and Medicare, Ryan-White funding is discretionary, which means that Congress sets the budget annually. Now, this is a really important part and part of the motivation for this talk. Ryan-White has been flat funded for the last decade, despite a pretty steady increase in demand. And this has led to an environment of chronic resource scarcity. How mental health and substance abuse services are publicly financed is equally complex. A few funding streams include SAMHSA block grants, Medicare, Medicaid, state mental health agencies, the VA, ADAPs, and correctional facilities. And this gets to the inequities, which is that where you live in the US can really impact what services are available to you and also what you can afford. So my colleague and I did some research, and in our paper, we asked two main questions. First, we were interested in which mental health indications are most likely to be covered on ADAP formularies. And second, we wanted to know what state factors are associated with the state's early adoption of mental health drugs. So which kinds of states were more likely to adopt this innovation? I started by talking to Ryan-White experts at national organizations, academia, advocacy organizations, and the federal government to get a better sense of this problem. And then I took state-level drug formulary data that's compiled by annual reports from the National Alliance of State and Territorial AIDS Directors. I coded the data into 4 mental health indications. We looked at depression, bipolar depression, schizophrenia, and anxiety disorders. There are a few states that covered other indications, such as attention deficit disorders, but we focused on these because they were the most commonly included, and also they're widely discussed in the HIV literature. And we had our drug coding reviewed by clinical experts because there are some pretty quirky issues. Some drugs have multiple indications, such as lamotrigine, to treat bipolar depression and schizophrenia. And also there are some drugs like amitriptyline, which are commonly used off-label to treat the side effects of antiretrovirals. So I'm going to skim over this slide. At the end, I'm more than happy to take any questions you might have on the methods. Basically, what we did was a regression analysis, and we were looking at the time to adoption of mental health drugs by states. And we had 5 sets of outcomes. So we had 5 sets of regressions. First, we looked at the time to adoption of drugs to treat any one of those 4 mental health indications. And we also looked at the time to adoption of drugs to treat depression, time to adoption of drugs to treat bipolar disorder, time of adoption of drugs to treat anxiety, and also drugs to treat schizophrenia. And we looked at the adoption of at least 2 drugs in each category to account for drugs that had multiple indications. So that way we could be a bit more confident that the drugs were on the formulary to treat that indication. These were the 7 state-level factors that we considered as independent variables, and they were informed by our expert interviews. First, we looked at a state's case burden. Second, the size of a state's federal Ryan White allocation. So some states get much larger dollar per case allocations than others. Third, we looked at political orientation. Fourth, total taxable resources, which is a measure of state wealth. Fifth, whether a state passed a mental health parity law, and if so, when. Sixth, the number of psychiatrists per population in the state, which could relate to the amount of professional lobbying and also the supply of providers. And seventh, we looked at the size of the state's mental health budget. And our hypothesis was that states with larger budgets per capita might have a broader commitment to treating mental illness. So to preview, we had 4 main findings. First, antidepressants were most likely to be included on ADAP formularies. Many states do not routinely cover other mental health drugs. The federal Ryan White allocation size, states' liberal ideology, and the number of psychiatrists per capita were all associated with earlier adoption of mental health drugs. And in addition, wealthier states were more likely to be earlier adopters of drugs to treat anxiety. So this plot shows the cumulative number of states that have adopted drugs to treat any mental health indication over time. And you can think about this as the diffusion of innovation that Dr. Fenton talked about in his talk. And this is not whether states currently cover these drugs. It's really just whether a state has ever adopted the mental health drugs at that point in time. And what we see is that the number of states that have included mental health drugs over time has increased since 1997. However, by 2008, which was the end of our study period, almost a fifth of states still had not included psychotropic drugs on their ADAP formularies. This chart shows similar information, but it breaks it down by indication. And there are 5 rows for each outcome. And the columns show the percentage of states that had adopted these medications at 4 points in time. And here in the top row, we see that 10% of states had adopted drugs to treat at least one indication in 1997, and this increased to 82% by 2008. And this is exactly what the plot shows us. I thought it was pretty interesting, though, to compare the cumulative adoption by indication. And so what we see in the last column that I've highlighted is that of the 4 indications, antidepressants are the most likely to be ever adopted on a state's formulary, followed by drugs to treat schizophrenia and bipolar disorder. And by 2008, only half of states had ever adopted drugs to treat anxiety. Here are our regression results for the models that looked at the time to adoption of any mental health drug. And there are 2 models here. They're similar, except that I use a different specification for time. And 3 variables were statistically significant. First was the case standardized Ryan White allocation. Second was the state power score, which was our measure of political ideology. And third was the number of psychiatrists per capita. So what these results tell us is that states with larger Ryan White allocations, more liberal political ideologies, and more psychiatrists per capita were more likely to be earlier adopters of psychotropic drugs. So these are the regression results for the 4 indications. I know I broke every single PowerPoint rule since most of you probably can't read any of this. So I'm just going to tell you what you should be able to read if you could, is that states that have more total taxable resources, which was our measure of state wealth, were also more likely to be earlier adopters of drugs to treat anxiety. So this is what you should take away from our analysis. First, Many states have decided to cover mental health drugs over time, which is great given what we've been talking about all day. But there remain several states that have not yet adopted these medications. Now, this is not particularly surprising, but the size and scope of drug formularies really differs depending on where you live, and this variation is pretty persistent over time. So what this means is that states with pretty limited formularies are not necessarily catching up to their peers over time. And our regression analysis suggests that resources are a pretty key driver of a state's decision to expand its ADAP formulary. And this is also confirmed by some discussions that I've had with program managers. So the paper that I just presented, we do not include substance abuse medications. And the problem is that there weren't a lot of states that adopted substance abuse medications over time, so the regression models wouldn't converge. So for this conference, I wanted to present some pretty preliminary results that just describe the coverage of substance abuse medications. So I'm not looking at which states are more likely to cover. I coded the drug formularies for the presence of medications to treat alcohol, nicotine, and opioid dependency. I'm sure clinicians in the room will quibble with how I categorize this, but I did it based on NIDA's paper, and I'm happy at the end for any suggestions on how to do this differently. So this first plot is the cumulative adoption plot for states that have adopted at least one drug to treat substance abuse on their formularies. And this includes tobacco, alcohol, and opioids. And as you can see, by the end of the period, about 2/3 of states included at least one substance abuse medication. The second cumulative adoption plot looks at the time to adoption of at least 2 substance abuse medications. So similar to the mental health drugs paper, some drugs have multiple indications, so looking at least 2 drugs can increase our confidence that the drugs were truly included for this purpose. And here we find that only about 1/3 of states had adopted at least 2 substance abuse medications by 2009. This chart shows the cumulative percentage of states adopting any substance abuse medication and also medications specifically for tobacco, opioid, and alcohol dependency. And within each category, like before, I'm presenting the cumulative adoption of at least 1 and also at least 2 drugs in each category at 4 points in time. Drugs to treat tobacco addiction are the most commonly included. However, this is primarily because many states have adopted Zyban, which could have been included to treat depression and not necessarily for tobacco cessation. So if we're looking at least 2 drugs to treat tobacco dependency, there's only about 22% of states who adopted those. Less than 1/3 of states covered any drugs to treat opioid addiction, and 12% covered 2 or more drugs in this category. And only 1/4 of states covered any drugs to treat alcohol addiction, and less than 1/5 covered 2 or more drugs in this category. There are a few limitations worth mentioning. First, we don't consider the relative price or issues with brand name versus generic. We only have information on what drugs were on the formulary, so consequently, we really can't assess whether some subpopulations had worse access to these medications. We can't talk about why these drugs were included or how formulary decisions get made. And we also can't rule out the possibility that maybe some states have limited ADAP formularies because HIV patients can access psychotropic medications through other public programs. So I wanted to end with a couple of take-home points. So first, although there were a lot of studies about treating mental health and substance abuse among people living with HIV and why this is really important, to my knowledge, there hasn't been a lot of work on the political factors that affect access to psychotropic medications. And treating mental health and substance abuse is really important to implementing the National HIV/AIDS Strategy, which includes lowering HIV transmission and also increasing the quality and access to care. So I really think that it's pretty valuable to think about how our broader state and national policies can affect access to medications. So before turning the stage to Dr. Gruber, I'm going to mention some upcoming challenges and opportunities, which she's going to pick up on in her talk. So as far as opportunities, one of the major features of the health reform legislation that is applicable to people living with HIV is the Medicaid expansion. So this is a real opportunity to increase healthcare coverage to this population. In addition to the upcoming Medicaid expansion, there's a new and hopefully improved federal mental health parity legislation. And this new legislation addresses both mental health and addiction for the private insurance market. And third, the longstanding ban on federal funding for syringe exchange programs has recently been repealed. As far as I know, there's been no new money committed to this, so this might be primarily symbolic. But it's symbolic in that it can really signal some changing attitudes among federal policymakers towards this population. So that's a real opportunity moving forward. So I have to end with something terribly depressing. First, the recession has led to some pretty chronic state budget problems. And that may affect state budgets for mental health agencies. And it may also affect ADAPs because many states provide an additional state contribution to their program. So for example, a lot of drugs were recently dropped on the 2010 formularies, and now we're seeing increasing wait lists. Second, the Ryan White program is scheduled to be reauthorized in 2013, but remember that the Medicaid expansion is supposed to happen in 2014. So with health reform being rolled out, it's really uncertain at this point whether the program is going to remain funded at its current rate, if it's going to exist at all, or if it's going to be fundamentally altered. So that's a big question mark that's out there. Third, in theory, more people living with HIV will have access to insurance through the Medicaid expansions. But that doesn't necessarily guarantee access to psychotropic medications if Medicaid formularies are limited or restricted. And finally, with the upcoming elections, who knows what's going to happen with health reform? Who knows what's going to happen with state budgets or federal support for HIV care? So with those somewhat depressing thoughts, I'm handing over the floor to Dr. Gruber, who's going to talk about these challenges from the perspective of someone who's in the field and working with the realities.
So just to pick up on what Dr. Martin just said, we originally hoped to have 2 or 3 state AIDS directors to come by to be able to talk about the situation in their individual states, some that are well-resourced, some that are medium, and some that are less resourced. But a lot of them are not allowed to travel. So they're not at the National HIV Prevention Conference. But we were lucky enough to have Dr. Gruber from Louisiana to come. DeAnn Gruber is the Administrative Director of the Louisiana Office of Public Health HIV/STD program. Dr. Gruber's experience includes more than 20 years in the HIV/AIDS field, initially working with HIV-infected women, children, youth, and families at the FACES program of Children's Hospital in New Orleans from 1989 to 1999. Since 2003, she's worked with the Louisiana Office of Public Health HIV/AIDS program, and her areas of expertise include program management, administration, planning and evaluation, and resource development and grant writing, all good social work skills.
Good afternoon, everyone. First of all, I'd like to say that Dr. Martin and I were very relieved that we both got the memo to please be sure that we had our hair cut short and our gray business suits on today for our presentation. And so when we met each other this afternoon, it was a nice exchange. I'm here today, and first of all, I'd like to thank Kevin and the entire team of CHIPTS to invite me to basically respond to Dr. Martin's research, and I'm coming here today from the perspective of a state AIDS director. I don't have a PowerPoint presentation, and instead I'm going to be speaking more from experience and situation of what is happening from one state's perspective of Louisiana, but also I know that with the other state AIDS directors, the continuous conversations that we're having related to ADAPs and what's going on with the programs and how we can be able to extend coverage to individuals living with HIV and AIDS and make sure that they can get their needed medications. I recognize that I actually do have one of my fellow colleagues, state AIDS directors here, and perhaps at some point, if he also wants to share, then we'll see if we can coax him up here for a few minutes. So, and then I also do want to say as well that I come from a perspective of as a social worker, and even though it's been many years since I've done clinical services, I still feel that I have very strong core values of mental health and substance abuse treatment, and embrace that as a state AIDS director as well. And I think the first thing that I want to say is that after reading Dr. Martin's research, in many ways, the state of Louisiana certainly does support her findings. And you know, Louisiana, as many of you know, is not a wealthy state. We're a very poor state as far as our state general funds and what is allocated for, especially for HIV/AIDS services. Unfortunately, the state has never allocated dollars specifically for our ADAP program. Despite advocacy, despite continued education and pleas, and then that still has not happened. And in fact, with the current budget shortfalls over the last 2 years, we've seen our state general funds dollars whittle from $2.5 million that's been directly allocated to our program, which isn't a whole lot of money, to zero, effective July 1st, 2011. And so we very much then are dependent on federal dollars as well as then other resources and programs that we can collaborate with to be able to provide services for individuals. The other piece is that we, and so I guess then to say that, being a poor state, please come down to New Orleans at any time, spend your money in our city, our wonderful city, and because you know your money that comes into our city does certainly help us overall. Couldn't pass that one up. The second thing I just want to say is that Louisiana also has a very conservative political ideology. Our governor, who a few years ago we felt like had strong aspirations to become the next vice president or president of the United States, those aspirations with Governor Jindal appear to be kind of tamped down a little bit, but we never know where he is. But in the meantime, he has a very, very conservative agenda in his administration. And so it's very challenging as we proceed to not only, try to offer services to individuals, but to expand related to mental health services is not necessarily up at the top of his list. And then I think the other thing, too, of the limited number of psychiatrists, I thought that was an interesting piece that Dr. Martin had put into her research, and we also, again, experienced that, and I think it was even more evident 6 years ago after Hurricane Katrina. And for a while, all of a sudden, the mental health issues that were coming out from individuals, not just those who were HIV positive, but individuals throughout the southeastern part of the state, and the need for mental health services and the very much lack of resources that were available became very, very clear. And so we have an awful lot of challenges, but at the same time then we see the needs that are there and are very much committed to identifying how can we then continue to work. And so some of the things that, when Dr. Martin says that 82% of the states have never included mental health drugs on their formulary, Louisiana is in that other 18%. Where we have always, and I want to give you a little bit of a perspective, I think, from a historical context of our ADAP program. And we have always had a very limited formulary primarily due to resources. And so, it wasn't until 2007 that the only drugs we had on our formulary were those that were antiretroviral drugs. And in 2007, we then saw that we had maybe a little bit of money that was going to be left over, and part of it was because of post-Katrina issues. We had a lot of individuals move out of our state after Katrina. And so we then reassessed, and we said, this is then now an opportunity for us to expand. And so what we did was we pulled together our ADAP advisory group and we asked them to review our formulary and to identify what would be a critical classification of drugs to now be able to offer. And mental health drugs were discussed. And there were some individuals who felt it was very important, especially, again, this was a few years after Katrina, that we were experiencing and identifying a lot of people who were dealing with depression and post-traumatic stress disorder and other conditions. And yet the group overall decided, no, let's do opportunistic infection prophylaxis. So in 2007, we added those drugs. It's still very, very limited, restrictive formulary. The next year, we then added, we changed our criteria that we went from 200% to 300% federal poverty level. And we also offered that for about 6 months there, we were going to pay for laboratories. And so that was 2007, 2008, 2009. Beginning of 2010, as we are on a quarterly basis or more frequently as needed, looking at our data, all of a sudden we're realizing that our projections are saying from 2008 to 2009, we enrolled, our number of people served went up by 15%. 15%, okay, that then means that people are coming back, we're able to get individuals into the program, but our expenditures went up 33%. And with the expenditures going up so dramatically, we then got to the point of realizing that if we didn't do something, and then we were not only going to not be able to enroll people into the program, but we were going to potentially have to disenroll individuals because we could not continue to maintain them for the entire budget period. And so in June 2010, we made the very difficult decision of closing our ADAP program and starting a wait list. In the last 14 months, we have had cumulatively a little over 1,500 individuals on our wait list. Right now, as of a few days ago, we have just over 950 individuals. We have been able to take over 500 of the total cumulative and move them either now back into ADAP because we've received some new resources over the last year from both HRSA, and also we have aggressively gone after rebates. And there are pharmaceutical company rebates that we can get, and that we then have been able to bring those in and to increase some amount of resources to bring people back into ADAP. But we still have almost 1,000 persons, and every week it goes up about, on average, about 25 to 30 individuals. And so it's this continued challenge again of how to manage this, and with the current situation that basically there are 12 states in the country that have wait lists. And so we, at this point, or really I guess what we've continued to do is look to other resources. And as Dr. Martin mentioned, of where are the other resources. And so one thing that Louisiana has going for it is that we have a very, very generous Medicaid program. And so for individuals who are eligible for Medicaid, and then there are really minimal drug restrictions. And so they have access to prescriptions. And also, about 6 or 7 years ago, the state legislature had implemented a cap on how many drugs an individual could receive each month. And they put a cap on of no more than 5 prescriptions filled each month. And however, through a lot of advocacy, we were able to change that for persons living with HIV, and so that there is no longer that kind of a restriction for clients. Medicaid certainly, though, isn't the answer for everybody, and there are still gaps in coverage, even if you were on a Medicaid plan. That for some Medicaid plans, the drugs are not covered. And so currently, there are still definitely some gaps. I think some of the other resources that we've looked at have been collaborating very much with our Office of Behavioral Health and being able to refer individuals into their services and their clinics for treatment and care. And then the other thing is we really have turned to our Part A partners. We have 2 Part A cities in Louisiana, New Orleans and Baton Rouge, and those Part A partners have agreed to pay for drugs that are not covered by ADAP, including mental health drugs. And so those are some of the things that we attempt to, to continue to do to try to get these services out there, working in a very challenging environment. The other piece I want to say too is, we really do see on the landscape what is the question, or it's not really a question, but what is the situation of what's going to happen with healthcare reform? And when we look at healthcare reform, I think and I don't think many people are saying this, but there are still these hopes, or, is healthcare reform, is it going to be the magic solution related to access to care and being able to receive the medical services that are needed? And I think that we're certainly much more realistic and say we're not totally sure what is healthcare reform going to look like, but what we're going to do, we are identifying places where there are opportunities that we can stretch our ADAP dollars further by being able to get individuals enrolled into health insurance plans and pay for their premiums and their copays and deductibles, or that we can enroll them into the pre-existing condition insurance plans, or PSIPs, and those will go our dollars will go much further versus just paying directly for the drugs. And so there's certainly then much more focus and emphasis on how we can do that across the country with our ADAP programs. And I guess, the other, it's been already mentioned by Dr. Fenton and Kevin about the fact that with ADAPs going through this crisis now of how much it does impact the South. And even though it's been stated a few times already today, I just want to one more time emphasize that yes, out of the 12 states that have ADAP waitlist, 8 of them are in the southern region of our country. And also out of the 9,217 individuals who are currently on waitlist across the country, 96% of them live in the South. And that is a very, it's just an alarming number of then what is going on in our country but I also think too that those states, again, really, Dr. Martin's research is supported by when you look at some of the characteristics of resources and political ideologies and other types of things that are going on in those states. It very much is, you look at the South and you see that reinforced. The other thing I also just want to mention too is related to stigma. And I think that the stigma, it's been alluded to at some points around HIV/AIDS, but I also think around the stigma of mental health. And that we still have individuals who, the need to make sure that within our programs that we have case managers and that we have providers who they themselves feel comfortable talking to patients and clients about mental health conditions and needs, and that the patients then feel more open to be able to discuss some of these very challenging issues. And so I think that there's a need for education around across the board for increased awareness. So, those are a few of the, I think, just a quick 10 to 15 minute response to Dr. Martin's research. And I think, the themes include that, yes, we certainly do have an ADAP crisis in our country. And the resources are not there to be able to expand formularies and do other things. But I do still know that there are other mechanisms or strategies that we will continue to explore and implement on the state level, so that if it's not ADAP, then it's another way that we can then get these services provided to people who need it. And with that too is, of course, the need to collaborate and partner with researchers, with legislators and policymakers, with the communities and the advocates to make sure that we truly can get the services that are needed. So with that, it's just a few of my thoughts, and I feel like I'm addicted to PowerPoints, and so this was a little bit of a okay, but again, I want to thank you very much for inviting me, and I think we have a few minutes for questions.